Hello everyone, I have decided to make a separate video on the robotic finding of the jaundice because it's a really important topic. It's actually a 5-star topic because I think if examiner is going to give you any question from the from the jaundice topic, is definitely going to be from this table, the robotic findings of jaundice. So we will learn it. It's not that much difficult if you understand this mechanism. So let's get started. First of all, I like to mention here is that hemolytic jaundice is also called perihepatic jaundice because as we have already discussed in previous video, it happened before uh, our liver. And hepatocellular jaundice is also called hepatic jaundice because it is happening in our liver. And cholestatic jaundice, or in some books it is written as obstructive jaundice, is also called post-hepatic jaundice because it's happening after our liver. So if in exam you got any question where they have used the term hepatic jaundice, hepatic jaundice, post-hepatic jaundice, just do not get confused. It is the same thing. So now we are going to study this laboratory finding. This is serum total bilirubin. As we know, the jaundice is due to the deposition of the bilirubin. So this is going to be increased in every scenario. In in was hepatic, post-hepatic jaundice. Now is conjugated bilirubin. When our conjugated bilirubin is going to increase, is it going to increase? We have here our liver convert unconjugated bilirubin to conjugated bilirubin. So in hemolytic jaundice, problem is the excess breakdown of the red blood cell due to which uh, the capacity of liver is reached. We have surpassed the capacity of liver to convert unconjugated bilirubin to conjugated bilirubin. So that we have no problem with this conjugated bilirubin. Our problem is that our unconjugated bilirubin is increased. So conjugated bilirubin is normal in blood. The thing to remember here is we are discussing this value in blood. We are not discussing this value in our intestine because in intestine the conjugated bilirubin is going to be increased. Why? Because our liver is working at its maximum capacity. In normal circumstances, our liver is not going to convert that much unconjugated bilirubin to conjugated bilirubin. But now, due to some disease, we have excess breakdown of red blood cell, due to which our liver is converting too much unconjugated bilirubin to conjugated bilirubin, and now it is creating this conjugated bilirubin to our biliary system, to our intestine, where it is going to be excreted finally through our feces. So we have increased conjugated bilirubin, increased urobilinogen, increased stercobilinogen. Why? Because liver is working at its maximum capacity. But in blood, we do not have increased amount. In blood, conjugated bilirubin is not going to be increased. It's normal. Okay. Just keep this in mind where we are talking about our values. We are talking about this value in our blood. So conjugated bilirubin is normal in our blood but increased in our intestine. Now hepatocellular jaundice, definitely now happening here is that our liver is converting this unconjugated bilirubin to conjugated bilirubin. So from this point we suppose that conjugated bilirubin is not affected. Because our liver is not able to convert unconjugated bilirubin to conjugated bilirubin, but due to some liver disease, liver is actually excreting this conjugated bilirubin in our blood instead of excreting it into our biliary system. Okay, due to liver disease, we know that due to liver disease, unconjugated bilirubin is less converted into conjugated bilirubin, but the converted conjugated bilirubin, although it is less compared to the normal saturation, but it is going to be excreted in our blood, not going to be excreted in our biliary system, which transported to intestine. So in our blood we have increased value of conjugated bilirubin, and in cholestatic jaundice, absolutely we have obstruction here, due to which conjugated bilirubin is not able to make its way to intestine. So liver has no other option rather than excreting it into our blood. So it is definitely going to increase. About unconjugated bilirubin. So here we are clear that excess breakdown of fat blood cell, due to which we have increase in our unconjugated bilirubin. And in hepatocellular jaundice, we know the liver is unable to convert this unconjugated bilirubin to conjugated bilirubin due to liver disease. So we have increased amount of unconjugated bilirubin. And about the cholestatic jaundice and obstructive jaundice, we have no problem with unconjugated bilirubin. Unconjugated bilirubin is normal. Problem is that we are not able to excrete the conjugated bilirubin. So this is going to be normal. Now another marker I like to discuss here is stercobilin. This enzyme here, which is actually formed when our conjugated bilirubin is converted by our bacteria to unconjugated bilirubin, which is then converted into the stercobilin. So what will happen to the amount of stercobilin in our different type of jaundices? So in the stercobilin, in the pre-hepatic jaundice, hemolytic jaundice, we know that this is actually going to increase. Why? Because as I already told you, we are making conjugated bilirubin at its maximum capacity, and conjugated bilirubin is actually increased in intestine, due to which we have more stercobilin. Okay, and I already told you in first lecture that stercobilin is related to the color of our feces. So let's add here color of feces. The color of feces is going to be dark. In hemolytic jaundice, the color of feces is going to be dark. In the hepatocellular jaundice, actually in what is happening in hepatocellular jaundice is that our liver is excreting the conjugated bilirubin into our blood, but sometimes it is because whole liver is not affected by disease. Some part of liver is also working normal. They are excreting it into our biliary system. Like if this part is affected due to some disease, this part of liver is normal, so it is going to excrete in our biliary system. So we have some conjugated bilirubin in our intestine and some in our blood, due to which it may be the stercobilinogen may be reduced, or it may be normal. When we are excreting in our blood, it is reduced, and when we are excreting in our biliary system, its value is quite near to the normal. And the same will happen with the color of feces. If it is less, they are clay, light colored, and if it is normal, they are dark brown color, the color of normal feces. And in the cholestatic jaundice, we are not able to send any conjugated bilirubin in our intestine, so the stercobilin is definitely going to decrease, and we have clay color feces. Okay, now the other markers I like to discuss here is urine bilirubin. The first thing I like to mention here is that I think these markers are really important compared to other markers. There are many other markers, but there is 90% chance if examiner is going to test you, he is going to test you among these markers. So remember these markers with your hand. You can, and I am going to discuss these two markers. These two are important, but not that much. These are 5-star, and but you can say these markers are also 3 stars, and there are some other markers that are not that much important, so I'm not going to discuss them. So with the urine bilirubin, so the unconjugated bilirubin is actually bound to our blood proteins like albumin. so it is not going to be excreted through our urine. It is not water soluble, not going to be excreted through our urine. The conjugated bilirubin, however, is water soluble. It do not bound to protein, so it is going to be excreted through our urine. So in the hemolytic jaundice, we have a lot of unconjugated bilirubin, but conjugated bilirubin is normal, so urine bilinogen is negative, but it is positive in other two types, hepatic and post-hepatic jaundice, because we have increased amount of conjugated bilirubin. And about your bilinogen, the your bilinogen is here, which is found when the conjugated bilirubin is converted into the your bilinogen. Thing happening with the your bilinogen is that our small intestine actually absorbs the food. So our small intestine is going to also absorb some amount of the your bilinogen and going to absorbing it from a small intestine and releasing it into our blood. From blood, some of which is again taken by the liver and some of it is excreting in our urine. So if we have more conjugated bilirubin reaching our intestine, more urobilinogen is formed and more is absorbed in our blood. So it is increased in hemolytic jaundice. Why? Because more conjugated bilirubin is reaching our intestine, and it is slightly increased in the hepatocellular jaundice because due to we have already discussed, because some of the conjugated bilirubin is definitely going to make its way here, and in the cholestatic jaundice, due to obstruction, no bile is reaching intestine, so we have this decreased or completely absent. So that's all. If you understand this mechanism, you are definitely going to make you are definitely not going to confuse this value in your examination. But if you are unclear with it, you are definitely going to confuse it. So my advice is to make yourself comfortable with this mechanism and think what thing is happening in which situation. So another tip is here, if about hepatocellular jaundice, if you is following it, seen it, most of the values like unconjugated bilirubin are increasing in it, except steatobilin. So keep this in mind. Okay, that's all from this lecture. Uh, and I have prepared an MCQs for you. This is actually from the past papers. So jaundice with the clay color stool is most common in. Now let's break down these MCQs. He is saying the clay colored stool. So we know that from the laboratory finding, the clay color stool is going to be in the obstructive jaundice. You can go back in the video and see about this clay colored stool with design obstructive jaundice. And what we have discussed it in the first video, that hepatic the obstructive jaundice is happening due to the pancreatic head carcinoma, and we have also discussed a sign related to it. Is the hemolytic anemia? It is the first pre-hepatic jaundice, and liver cirrhosis, it is hepatic jaundice, and leptospirosis, it is not related to this option. And this type of MCQs is going to be appear in your examination. So if you make yourself familiar with the mechanism, that's all you need to know. Thank you.